So, refractive surgery in keratoconus. As I was telling Sanjana, this is a very wrong concept for me. Disclaimer: I don't do refractive surgeries in keratoconus. So, coming to let's briefly summarizing. This is my preferred choice for cross-linking, and in keratoconus, for me, the aim of treatment is to make the patient see well in whatever way it is possible and prevent the disease from progressing. So that is where the so-called plus procedures come with CXL. So any procedure combined with CXL, you can call it a CXL plus. So these are the various plus procedures available, and definitely I don't do clear lens extraction for keratoconus. I don't do any LASIK or PRK for refractive correction in keratoconus. Most of the cases which I see either which require cross-linking either undergoes a PTK or a topo-guided PRK. Then some of them intracorneal ring segments, and very few phakic lenses. This is what I do. Now we'll come to cross-linking with PTK. The machine which I have access to excimer, EX500. So we use a 6.5 optic zone with 8.3 millimeter diameter ablation zone, 50 microns ablation for all cases. This is followed by an accelerated cross-linking, and this is a small data which we had done initially when we started doing PTK compared to mechanical debridement. So when we do PTK, the obvious question that is asked is, why subject the patient to PTK? It's additional expense for the patient. Is there any advantage of doing a PTK along with cross-linking compared to manually debriding the epithelium? So that is the reason why we took out this data. So this is what we got the results as. Vision, uncorrected vision improved early in this group of patients who underwent PTK. But then the best corrected vision, there was no significant change in between the groups. The group which had PTK with cross-linking was compared with mechanical debridement, showed a significant compared to the other one gain in the visual acuity compared to the manual debridement. More importantly, the loss of lines was much less in this group compared to mechanical debridement. This was kind of indirectly correlating with the amount of haze which was produced after mechanical debridement when we compare with PTK. Then there was no significant difference in any other parameters between the two groups. So when we compared these two groups, what we found was there was a rapid improvement in vision, better slight improvement in lines of vision or corrected vision, but more importantly what we felt was that the possibility of having a reduction in vision post C3R was much less in this group compared to mechanical debridement, and that is the reason why we prefer this procedure. Now practically in our institute, in almost all cases we do PTK. Okay, mechanical we have kind of shelved. Next comes the topo guided PRK. Now this gives a wrong impression that when we do topo guided PRK you are going to correct the refractive error. No, that is not the idea here. The idea of doing a topo guided PRK in keratoconus is to regularize the corneal surface, okay, to reduce the irregularity at the central 3 or 4 millimeters so that the corrected vision improves. It is not to give a spectacle free life to this patient, and that is not the idea. That's why I said that the idea is not refractive surgery here. It's to make the C patient as good as possible with whatever simple techniques which he can use. So this is the criteria which I follow. After the ablation there should be at least 350 microns of bed remaining, maximum ablation probably up to 60 microns, and the correction in topo guided PRK which I would aim for is about 60 to 70% of the cylinder. So whichever is lesser or is attained earlier, we do that. And then I use mitomycin. There are lots of reports coming that you don't need mitomycin in these cases because when you're doing C3R you are kind of killing the keratocytes and there is no possibility of haze. But then my clinical experience has been otherwise, so I use mitomycin in all these cases and then do a accelerated cross-linking. So as you can see here, there has been a significant, amount of improvement in both uncorrected and spectacle corrected vision in these groups. And all these cases where the corrected means is spectacle corrected, because we are not thinking about contact lenses. So cylinder, again, significant reduction in cylinder, significant flattening of the cornea. So as you can see in this picture, the upper one is a pre-topo guided and the lower one is a post-topo guided. Though it doesn't look very different, though, what you can actually see here is, if you see in the upper one, the steep area, that the red area is slightly on the lower part, while in the lower one, the red area is slightly on the center part. That is exactly what is meant by regularization of the cornea. Okay, you are pushing the cone towards the center, or it becomes, so the pupillary area becomes, a smooth dome, which can be corrected either with spectacles or contact lenses. And as you can see in this picture, there is a significant reduction in this Kmax. Okay. So yes, topo-guided PRK with CXL produces a good amount of visual improvement with significant flattening of cornea. Now, the other procedure which I do is a intracorneal ring segment that I use in TAX. It is a combined procedure, various techniques I have described, but then what I prefer is intacs first or ring segment first, followed by cross-linking. Generally, I don't prefer to do both together, because I would like to assess what is the effect of one and then proceed with the next one. So this is an example. Again, the idea here again is the same as topo guided PRK. You're just trying to push the cone to the center. Okay, and make the central pupillary area much more regular. Yeah, so this is the a difference map showing the post, pre, and then the amount of flattening the procedure produced. So CXL plus has got definite pluses, but in keratoconus management. But then in refractive surgery, personally, I don't do it and I don't advise. So this is a rough algorithm. This is not a perfect one, but this is what I generally follow in my clinic, with a lot of ifs, buts, additions, deletions based on each patient. Thank you.
Thank you very much, sir. As rightly said, refractive surgeries in keratoconus is a very dicey decision, because we are responsible for their future corneal aberrations which are going to be created, or corneal bending. So most of the time the challenges faced is when a refractive patient comes and accidentally we find out that this patient is having keratoconus. So in these conditions, as sir said, if the vision is 6/6 and the patient is really eager to undergo a refractive surgery, we need to give them a reality check that in future their cornea can get damaged. So if the patient's age is about 35 years, most of the time if it's a male patient, then it is the patient's risk on which procedures would be considered. So that is why it's very important for us to tell them the true facts about refractive surgery. So now I would request Dr. Anita madam to take the dais. So madam will be talking about vision corrections which are non-surgical, that is mainly the contact lens usage. So Dr. Anita madam is a senior consultant at Trishur Hospital, as well as she is the unit chief at LF Angamali. So madam has lot of papers in the department of cornea and has multiple presentations to her name. Kindly take over, ma'am.
Good morning. So we are privileged to be the opening batsman of our annual Drishti conference, and wishing our annual conference Drishti 2024 a huge success. So I'll be talking about, so I have been asked to talk about what is modern, what is happening in the contact lenses, what are the developments in the contact lenses, options for keratoconus. So the objective of my presentation is to understand the latest advancement in the contact lens technology and to discuss the benefits, challenges and indications for the newer lens designs. We all know that spectacle correction has a limited role in irregular corneas, but it can be used in early cases. But there is disadvantages for these spectacle options because of the high amount of corneal toricity, the changing refractive error due to the progression of the disease, because they will be having fluctuating visual acuity with the spectacles. So we traditionally treat them with whatever available, that our RGP or the rigid gas permeable lenses, and nowadays clearer lenses is also widely used. And of course, there are challenges for a contact lens practitioner because in addition to good vision, the patient always requires comfort and lens tolerance. Otherwise, they won't use the lens. And also, aftercare visits are very important to know the progression of the disease, to assess the fit of the contact lens, and to know whether any pathological changes are happening with the contact lens wear. So first we will see what are the advances in the contact lens technology. Now, so many materials like hyper decay materials with good water content for enhanced oxygen permeability is coming up, and other designs like the hybrid lenses, scleral lenses, custom soft lenses with high modulus lenses which are specially tailored for keratoconus. What are these high modulus lenses? They are